Thank you everyone for being here today. Thank you for everyone who's joining online. This is the Learning Health System Collaboratory April event. I'm Alexandra Vincent, Assistant Professor in the Department of Learning Health Sciences. And on behalf of my co-organizers, Ed Hurwitz, who I believe is joining online today, and Chuck Friedman, welcome to our event. It's really a great pleasure to have Mark Williams with us today. Mark is a clinical geneticist and research scientist. He's professor and director emeritus of Geisinger's Department of Genomic Health and a member of the NHGRI Genomic Medicine Working Group. He also was a member of the Secretary's Advisory Committee for Genetics, Health, and Society and served as president of the American College of Medical Genetics and Genomics. Mark is funded through an NHGRI Genomic Learning Healthcare System grant, which I hope he tells us about today. He's authored over 250 articles on a variety of topics, including the economic evaluation and value of genetic services, implementation of genomic medicine, the use of informatics to facilitate genomic medicine and precision health, and genomic learning health systems. We're excited to have Mark with us today to talk about patient-centered precision health in a learning healthcare system, Geisinger's genomic medicine experience. Thank you and welcome.
Thank you. It's a pleasure to be here. This is actually the second time that I've spoken at the University of Michigan at Chuck's invitation. Chuck and I got to know each other way back in the dark ages of the W administration, when there was a thing called the American Health Information Community that Chuck actually ran. And one of the things that he was prescient enough to anticipate was the need to have some emphasis in personalized health and personalized medicine. And so we did some interesting work on family history, and that was really my first introduction in terms of national informatics policy. And so fortunately, we've had opportunities to be able to keep connected over the years. So if any of you were, I know Chuck was there, but if any of the rest of you were there at my talk, and you have really good memories, some of this will be familiar right at the outset because I haven't changed my slides because I think they're really important and people seem to relate to them. But my objectives today are to talk about the MyCode Community Health Initiative, talk about genomics, precision health, and learning healthcare systems, how those work together. I'm going to provide a little bit of information about the Learning Healthcare System program that is currently funded through the National Human Genome Research Institute, and also going to present our experience with implementation of genomic medicine in the context of an integrated healthcare delivery system. And Geisinger is, we're technically an academic medical center. I've avoided working in academic medical centers my entire career. I've worked in integrated healthcare delivery systems, meaning that there are hospitals, insurance companies, physician organizations all under one roof. In my view, it's the only rational way in the United States to talk about how we can actually improve care. But Geisinger decided a few years ago to buy a medical school, so they got me, but they had to buy a medical school to do it. I'm not sure it was worth the cost. So, all right, let's see. Advance. Here we go. So I want to talk about precision medicine and precision health. I think it's important to have you understand how I think about this, and also understand that there's really a long history in terms of how we've used these terms. So first of all, I'm going to talk about genomic medicine. I'm trained as a geneticist, and genomic medicine includes traditional single gene disorders, genetics, which is what I was trained in. Now, an analysis of whole genome or subsets of the genome, such as an exome or pharmacogenome, but also still includes family history. And we tend to, say, well, that's pretty boring. There's not a lot of technology associated with family history. But family history still captures things that we can't capture through genomic sequencing, which is shared environment and genome environment interaction. And family history provides a surrogate for that. So it's still really an important piece of the puzzle. Now, we used to talk about personalized medicine. I'm going to tell you why we don't talk about personalized medicine anymore. But from a historical perspective, this is not a new concept. And as I was trying to find a good definition for personalized medicine, I had to go back almost 40 years to Steve Pauker and Jerome Kassir, where they describe personalized medicine as the practice of clinical decision-making such that decisions made maximize the outcomes that the patient most cares about and minimizes those that the patient fears the most on the basis of as much knowledge about the individual status as available. I think they really nailed this definition, and there are several reasons why. First of all, it's a bit heretical for me to stand up here as a geneticist and put forward a definition that doesn't explicitly talk about genetics and genomics. But I think we need to get out of the mindset that somehow all of the answers are going to reside in genomic sequence. There's going to be other pieces of knowledge that we need to incorporate. And so if we don't think broadly about what's needed to make healthcare decisions, we're going to miss opportunities to personalize medicine. But the most important thing that they really put forward here is that this is a patient-centered definition of personalized medicine. And I think this is something we really tend to forget about. And Alexander and I had really nice discussions about this at dinner last night, about the importance of having the patients involved. And the example that I use is consider two patients with stage 4 cancer. Patient A says, I want cure. I want everything that is possible, whether it's traditional, experimental, non-traditional, whatever, even if it's a 1% cure, even if there's an extreme risk that I could die from the treatment, I want to be cured of my cancer. Or the other patient says, patient B says, what can you do to make my quality of life as optimal as you can for the time that I have left, because I want to spend it doing the things I enjoy doing. Well, we don't understand the fundamental difference between those two patients. We certainly can't provide personalized care. So I think I really like this definition. And I cite a reference there because that was cited by Zach Kahani in a paper that he wrote. And when we actually went back, it turns out this never appeared in that particular article, and as best as I can determine, has never actually appeared in the literature at all. So it's somehow, but we know it's attributable to Steve and Jerome. So, at any rate, it's just an interesting thing about how quotations sometimes evolve. So now let's move into a term that's a little bit more contemporaneous, which is precision medicine. And this I take a lot from a book by Clay Christensen from the Harvard Business School called The Innovator's Prescription to Disruptive Solution for Healthcare. This is now, approaching 20 years old, but there's still a lot of really interesting things in this. And he asserts correctly that what we practice now is intuitive medicine. We care for conditions that are diagnosed by symptoms, and we treat with therapies with uncertain efficacy and watch for an empiric response. So essentially what we're doing is empiric trial and error. And he envisioned a time in a precision medicine time where the provision of care for diseases that are precisely diagnosed. So it's not you have diabetes, but you have this specific type of diabetes that we understand very well at a fundamental and pathophysiological level, which informs how we're going to treat you, because we know that based on our protocols and rules that this treatment is going to be the most effective for you. And we also have other information that tells us that we want to avoid this particular medication because you could have an adverse event. So that's the precision that we're striving for. So, and I do expect genomics to play a key role in this, but I don't expect it to be the only data that we're going to need to do this. And then lastly, precision health is just, we add the preventive elements to precision medicine, where we're not using population-based interventions for prevention, but we're saying based on your individual risk factors, this is the personalized precision preventive care that we want to initiate from you. And so what I'm going to be talking about in just a bit, the MyCode Community Health Initiative, is a population precision health effort. Now, inherent in all this are educational efforts that are directed at the participants, providers, payers, administrators, and stakeholders. And as I look at this now, upon reflection, I'm realizing I've fallen back into our traditional mode of thinking, which is a push mode. And we need to be in partner mode. So I'm going to have to redo the slide and say, well, we really need our partnerships around, these efforts with the different stakeholders. Now, the nice thing about my position is that in the Geisinger strategic plan, this is explicitly listed. So if people say, well, why are you doing what you're doing? I can point to the strategic plan of the organization and say, you said this is a strategy for the organization. So put your money where your mouth is. Now, I'm not going to spend much time talking about this because I think everybody in this audience knows this, but I always include these slides in my talks too. And again, these will be familiar, probably cause some uncomfortable flashbacks at times, since Chuck was a leader in many of these. But this is the idea of a learning healthcare system, best evidence, collaborative healthcare choices involving patients and providers, that discovery is a natural process of care. We create virtuous cycles, and we have to be able to use these things to ensure innovation, quality, safety, and value. So there's a series of 17 monographs, at least, from then the Institute of Medicine, now the National Academy of Medicine. And of course, one of them from 2015 that Chuck was the lead author on was this genomics-enabled learning healthcare solution. So it was really glad that was part of it. And here's a quote: healthcare system in which an infrastructure supports complete learning cycles that encompass both the analysis of data to produce results and the use of those results to develop changes in clinical practices is a system that will allow for optimal learning. So this was really great. I refer to this frequently. My only criticism, a mild criticism, is they probably could have used a bit more genetics expertise. They had a lot of informatics expertise, which speaks to me good, but a lot of it is about infrastructure. And we could have had a little bit more on the genetic care side, but that's a pretty minor criticism. So again, this is the way I kind of envision it. This was taken from the KP Washington Health Research Institute. You identify a care gap either through an internal or external evaluation. You develop a plan. You apply the plan. I learned something when I was at Intermountain Healthcare. We guaranteed all of our solutions to be wrong or your money back. Now, the second part of the guarantee was we will fix them through the study and act part of it. So we know it doesn't matter how many smart people you sit in a room to come up with a solution. When you actually put it into the real world, it's going to break. And as long as people know that you're committed to fixing it quickly, they're willing to put up with this cycle. And then the last thing that I think we sometimes forget about is that we have an obligation to disseminate and let others know about our successes. So it's not just success for us, it could be success for many. Now, Alexandra mentioned that I am a member of the Genomic Medicine Working Group of the NHGRI. And so what that has allowed me to do is to participate in strategic planning efforts. And so one of the behind the scenes contributions that I've had in the last two rounds of strategic planning was in 2010, they explicitly noted implementation as an important component of their strategy. First institute or center to really say, we're about implementation. In the 2020 strategic plan, I'd been indoctrinating them in my evangelical role about the importance of virtuous cycles and learning healthcare systems and saying, we know how to do this. And so this is a figure that's taken from the strategic plan that basically says the genomic healthcare system, we incorporate new genomic knowledge to improve the quality of care, new innovations. We collect outcomes data, analyze the data, and we feed that back into the basic genomics research so that where there are things that we discover that we don't know, we can use that to prime research that's going to provide answers that we can then apply back into care and to create this sort of figure eight of innovation and implementation. Well, it turns out geneticists have always done this, and it's because we're ignorant. When I graduated from medical school in 1981, the technology that we were really enthusiastic about was high-resolution chromosomal banding. So we could now detect, deletions of chromosomes that were, 5 megabases or that, which was a big deal because there were a whole bunch of people that had these that we didn't know about. Well, how do we do this? Well, we as clinicians, and this is my colleague Richard Pauly at the University of Wisconsin is we would take care of patients. And we would say, well, gee, I wonder what's causing this particular condition. And then we would partner with our basic science colleagues to say, I've got a bunch of patients that have this condition. Is this something you'd be interested in working on? Oh, okay. Then we would collaborate. We'd bring clinical data to the basic science researchers. They would find something, we would bring it back. And we didn't know we had created a little learning healthcare system because there wasn't that term around. We didn't even know we had a virtuous cycle because that term wasn't around, at least not in medicine. It's in engineering. But that's what we were trained to do. So all of us that practice genetics encounter individuals with rare undiagnosed conditions. We all run our own undiagnosed diseases clinics, and we use this type of collaboration with our basic science colleagues to make new discoveries. And ultimately, Rich's work, particularly with individuals with achondroplasia, led not only to the discovery of the genetic cause of achondroplasia, but he also then synthesized what he learned through his clinical care into clinical care guidelines for this rare disease, which are now, used by anyone that cares for children with achondroplasia. So we've had a natural affinity for learning healthcare systems, even though we didn't know it. So let me transition now and talk about our MyCode Community Health Initiative. So we have over 300,000 Geisinger patients that have consented to participate in this research project that will have exome sequencing and high-density genotyping. We evaluate those exomes for medically actionable results, and we return those to the participants and their clinicians. And then we also have built into this an initial care program through the research project that transitions seamlessly into clinical care. So we can translate these individuals with these conditions into clinical care setups that will support them throughout their lifespan. And because we're an integrated system, we also talked to our insurance group and we said, this is what we're doing. We're going to be recommending different types of strategies for these individuals. We want you to pay for it. And they said, it makes sense to us. And so we're not putting our patients in the position, our participants in the position, transitioning to patients where now they have to navigate the system on their own and they have an insurance company that's not paying for their care. So our vision is that our patient participants and their families are empowered to act on genomic information and prevent disease. And our mission is to implement this innovative, scalable clinical program that supports patients, families, and healthcare professionals in the routine integration of genomic results into care. And again, just to return to the patient-centeredness theme, we spent 2 years and convened numerous focus groups and interviews that involved hundreds of Geisinger patients to talk about what should this program look like? Should we return results? What do you want? And so it was really co-designed with our patients. And it's one of the reasons why when we approach people to consent this program, 75% of them agree to participate.
Is this across all departments at Geisinger?
Yes, yeah. So this is a system-wide initiative, although we use the vast majority of people are in-person consented, and so we move our consenters around to different sites, and we focused a little bit more on primary care clinics, pediatrics, internal medicine, family medicine, although we do have some presence in some specialty clinics as well. So we have a genomic screening and counseling program, which is the engine that makes decisions about what we should be evaluating and returning. We have a broad range of experts that participate, developing a consensus on which genes we should evaluate and return. We review that on a regular basis using multiple stakeholders. It's important to recognize this is a screening program. This is something, I don't think we have a lot of geneticists in the audience, but this is something I have to enforce to our geneticists. We only return pathogenic and likely pathogenic variants. Why? Because Bayes tells us that the prior probability of finding a condition in this population is very low. So if we started to expand our specificity to include variants of uncertain significance, almost everything we're going to be returning is going to be false positive. So we're going to be generating huge amounts of anxiety, cost, waste, chasing things that aren't. So if you have an indication, you have a very high prior probability that we're going to find something. And so we want to be more sensitive and make sure that we don't have filters that exclude potentially variants that could have relevance. But in a screening scenario, we have to flip that and think about this from a specificity perspective rather than a sensitivity perspective. We only want to call the slam dunk positives. We know we're going to miss folks. We hope that we're creating clinical systems that will allow those folks to come to evaluation. The other thing that we do is that knowledge changes rapidly, including in terms of genes that are involved, variants that are involved. So every time we have a new batch of patients that have been sequenced, we not only run them through our filters, but we run all of the rest of the people that have been sequenced before through the filters. So some of our early participants, their sequences have been run through 5 times. And so we're identifying individuals from those first cohorts now based on new knowledge that says, you know, we didn't find anything when we first looked, but now we know that there's something that you need to pay attention to. And then, of course, we built the infrastructure. Our gene list, here's basically the criteria. Is this gene actually associated with disease? Any of you that might be involved in clinical testing, there are gene panels out there say, oh, you've got chronic kidney disease, run our kidney disease panel. There are 350 genes on the kidney disease panel, of which 20 have a very strong gene disease association, meaning you're going to get information on variants in 330 genes for which we really don't know if it's associated with chronic kidney disease or not. Not a good way to run a program, even a diagnostic program, in my view. Can we do anything with it? In other words, we know that the ApoE4 is associated with increased risk for Alzheimer's disease. Can we do anything? Is there an intervention? No, there really isn't. So that's not something that at this point we're going to be returning. There is another process that's run by the American College of Medical Genetics and Genomics that looks at secondary findings, so that if you have a sequence done for an indication, we say these are genes that you should look for incidental or secondary findings. We use that information to also inform our screening program, although we don't necessarily mimic that. And then we ask questions, do we have the expertise? We don't want to create and identify individuals for which we can't provide services for them. And is there access to care? Can they get the care locally? Or is this something where we'd have to send them to Philadelphia or Pittsburgh? And for a lot of our population in rural Pennsylvania, traveling 10 miles is a big deal. And the idea of going to the big city, like Wilkes-Barre, is frightening to them. So, yes.
Question in the chat, was this for the general population? Or
Yes.
for those?
Yeah, so it's completely unselected. The only, the question was this for general population? So we had a legacy biorepository that was generated for the cardiovascular disease group that has about 15,000 samples that are part of the MyCode project, but that's the only population that's been, I take that back. That's the only population that was clinically ascertained, with the exception that we also have a obesity clinic, and we have incorporated MyCode into that particular clinic because of our legacy of research into etiologies of obesity. So those are the two, but that still represents, even with those two populations considered together, that still represents less than 10% of the total population of individuals that are in the MyCode Community Health Initiative. So we have a total of 73 genes that we're currently looking at. And some of these are what were defined as the CDC Tier 1 conditions, although with the recent administrative changes, you can't find anything on the CDC website anymore about CDC Tier 1 conditions, but fortunately there's a lot of literature about that. Those 3 conditions are hereditary breast and ovarian cancer, hypercholesterolemia, and inherited lipid disorder, and then Lynch syndrome, which is a predisposition to colorectal and endometrial cancer. Here's, as of March 1st, here were our numbers. We had nearly 361,000 consented participants, of which 262,000 have submitted samples. We've done exome sequencing on 230,000, and 208,000 of those have been reviewed clinically, and we've returned results we've returned 5,274 results to 5,206 individuals. Unfortunately, about 68 people had more than one.
Mark, what do the people who get no results, what are they told?
Nothing. And we tell them that up front. We say, if you don't hear from us, it doesn't even mean we've analyzed it. We just realized logistically it was very difficult. So we've had some general communications that have talked about analysis. And so they can kind of infer that, well, I've been through at least one analytic cycle, but we did not want to provide false reassurance. Because we've seen this even with 23andMe, where people come in, they have a family history of breast and ovarian cancer that looks like BRCA, and they say, well, I don't need testing because I had 23andMe, where they've tested for the 3 Ashkenazi variants. So they are conflating actual gene sequencing for BRCA1 and 2 with 3 variants. And so we didn't want to go there. So that was the decision that we made jointly with our patients, that we would just not inform about negative results. Now, we do have a very small, I'm not going to talk about it, we have a very small clinical sequencing program where we had a pilot project with our insurance company where we had individuals that in a clinical setting had a clinical population exome screen done. And in that case, negative results were returned to those individuals with the caveat that, if you have symptoms that suggest, even if it's one of the genes there, you need to get formal testing because we're looking. Here's just 4 conditions, our most common conditions. You can see we probably have now returned over 1,000 BRCA1 and 2 results for hereditary breast and ovarian cancer, over 600 familial hypercholesterolemias, over 500 Lynch, and then over 500. We're returning for hereditary hemochromatosis, just the 262 C to Y homozygotes, the ones that are at the highest risk for developing iron overload and symptoms related to that. And then we have 3 pages of other genes that we've returned. Now, one of the things that's really critically important is outcomes. And so when we think about returning outcomes from the program, we realized there were really 5 categories that they could fall into. And this is work that was published by my colleague, Mike Murray, when he was with us. So we have group 1, which is we say, hey, you have a BRCA pathogenic variant. I know, because I had clinical testing and it's the same variant. Great, okay, good. So you would think, well, not a lot of value there. They already knew about it. But what we realized was that when we were returning the result, not everybody that had the clinical testing was receiving the recommended care. The typical sort of situation in healthcare systems, right? We know from the to err is human, that roughly 50% of people get appropriate condition-based care. So it's a coin flip when you go to your doctor. How reassuring is that? And so we were able to say, oh, here's some care gaps. You really should be doing this, or the guidelines have changed from when you were originally informed. So we do actually provide some value by updating information. Group 2 are individuals that have a condition, and again, we use BRCA as an example, so they've had breast cancer, but for whatever reason, they were never clinically tested. And now we can use that information to say, okay, you actually are at much higher risk for recurrence. And so we need to change your monitoring there. So we've taken a diagnosed individual and converted them to a more specific, precise diagnosis. Group 3 are individuals that don't have a expressed condition, but we say, geez, you know what? You're carrying this BRCA variant, you should have mammography. And when we do the mammogram, we find that they have subclinical breast cancer. So they actually have the phenotype, but they weren't aware that they had the phenotype. And we have 2 groups where individuals don't have the phenotype. Some of those folks will go on to develop the phenotype. Some of them are never going to develop the phenotype. And of course, it's that group 5 group that you say, well, what value have we really added to their care? Because we've gotten them all riled up about a BRCA variant. It turns out they're never going to develop breast and ovarian cancer, but maybe they have risk-reducing surgery. Maybe they have increased surveillance, adding cost, adding disruption to their lives, adding no value, except the fact when we think about genetics, we don't think about just the patient, we think about the family. And we've had many examples in this group where we've identified individuals in the family that because of cascade testing, following that variant through the family, we've identified individuals that are affected with the condition through this type of cascade testing. So if you take the broader view of value and think about family unit rather than individual, I think we can make a case that even in group 5, we've had some impact. Yeah.
Another question in the chat. They said, as you said at the beginning, what if you are saying more frequent monitoring and the patient says, no way, I'm not doing it? Is it then still worthwhile to have done the test?
It's a great question. So I hope everybody heard the question. So the answer is, what if the patient says, I don't care what you told me, I'm just gonna business as usual, right? Yeah, we never have that problem in medicine where patients don't follow our brilliant advice, right? So the adherence problem is an issue, and I'm gonna actually hold on answering the question because I'll have some data later from our outcome studies that'll directly relate to that. So thank you for asking and teeing that up. You know, little previews of things to come. So what we found is that about 1 in 100 individuals in our MyCode population has a variant in a gene that's either responsible for familial hypercholesterolemia, hereditary breast and ovarian cancer, or Lynch syndrome. So, you know, collectively rare, but I'm sorry, individually rare, but collectively relatively common. And actually, if we look across all 73 genes, just under 3% of individuals have an actionable finding based on our analysis. Now, if we think about outcomes, we can think about a whole bunch of different outcomes. And I know this is a little bit small, and I kind of apologize for that. But the outcome types are really important to consider. So the first 3 are all related to health outcomes. And I think this is something that we tend not to think about as often as we should. So I'm going to use hereditary lipid disorder as an example here. And we take pediatric patients as part of MyCode. So we could identify a 10-year-old individual with an LDLR variant that we would predict could lead to early onset cardiovascular disease. But the outcome of interest, the health outcome that we're interested in, which is prevention of myocardial infarction and stroke, is going to be 4 or 5 decades after when we return the result. Well, I'm certainly not going to be around to measure that outcome. I hope we have systems in place that are going to be measuring that outcome, but we would like to have some outcome measurement that we could use that's more proximal to waiting for the health outcome of interest. Because if we find in 50 years, hey, we're not doing the right thing, that's a lot of time wasted. Well, the good news is that we have a chain of evidence, which is we have an intermediate outcome, LDL cholesterol, which is a very good surrogate for risk for cardiovascular disease. And so that 10-year-old, we could do a lipid profile on that individual, and we could say, oh, you have an elevated LDL cholesterol. You're old enough that we can initiate statins. And we know that LDL cholesterol accumulates over time to ultimately result in the myocardial infarction. So if we can treat that lipid disorder and lower the LDL cholesterol, there's a good chain of evidence that suggests that we're going to improve the ultimate health outcome. Now, the easiest thing to count, though, is did they have a lipid test or not? That's a process outcome, okay? And it's the easiest to measure. They occur the most frequently, so they're convenient measurements. There is a chain of evidence, but we're that much more proximal to the outcome of interest because, as the question in the chat indicated, so they get the lipid profile, great. What if they don't do anything about it? He has an elevated LDL cholesterol and the doctor says, you're too young for a statin. And then they forget about it. Well, now we haven't had any impact on health outcome because we haven't changed the health intervention. So we have to tie, if we choose a process outcome, we have to then tie it to intermediate outcomes if they're available and ultimately to health outcomes. Now, occasionally we can actually look at a health outcome of interest, but that's pretty unusual for most of the things that we're looking at. Now, in addition to the health outcomes, there's also cost. We'll talk about that in a little bit when we talk about value. There are behavioral outcomes, which was the question, okay, great, we give them the information, do they actually change their health behavior? Because if we give them information and it's business as usual, then we're really not creating any improvement. And then there's also a whole set of patient-reported outcomes that we need to be attending to. How disruptive is this to my life? You know, if I have to come in for plasma apheresis every 3 weeks because of my lipid disorder, you know, that's a major disruption. Now, maybe it's worth it, but as a patient, I need to decide that. How does this empower me in terms of my self-care? How does it affect my perception of well-being? Because we know that perceived wellness is directly related to healthcare utilization. If you don't perceive yourself as being well, you utilize more healthcare. So all of these sorts of things need to be reported, and that, of course, then rolls up to system outcomes. The system is also interested in what we're doing. What are we incurring in terms of costs? We're building infrastructure here. How is that supporting our mission? Are we avoiding costs? And is that a good thing? Because if we're avoiding costs, are we also avoiding revenue? How is this impacting our utilization? Are we, you know, sending a bunch of patients into a system where we do not have the capacity to care for them, in which case we're creating a problem? There are some reputational things. Hey, Geisinger is recognized worldwide in some cases because of this particular program. It's very visible. And, you know, the leaders in the C-suite generally like that. And of course, we're also graded and reimbursed to some degree on patient experience. And so if our program is worsening the patient experience, that's not going to be a good system outcome. Ultimately, I'd like to talk about this and translate this into value. And so what is value? It's crudely some relationship between outcomes and cost of care. How much do you spend to achieve a given outcome? And if we think about outcomes, and this is something that has been really focused where we really need to think about outcomes from the perspective of the patient. There are the medical outcomes, treatment, prevention, safety. There are service outcomes. How many times do I have to come to the doctor to achieve the outcome? How much did you disrupt my life? There are informational outcomes, which we've highly valued in genetics. In other words, we don't have a lot of treatments, but we can tell you a lot of information, and maybe that can help you make lifestyle choices. And, you know, but we can't, it's very difficult to evaluate those economically. And it also gets into the, you know, how much are we willing to spend for somebody personally to say this is really highly valuable to me against a constrained cost of care. And I think in general, we do a very poor job of measuring the cost of services. We can tell you what we charge, but that oftentimes has no relation whatsoever to cost. So this is really complicated, so I decided, well, I'm a simple person. I'm going to try and make this simple. So I came up with this idea of a value plot. And so you have a medical or service outcomes on this column. And then we have a cost of care on the row. And you can say, well, if we improve outcomes and we decrease the cost of care, that's a win. No one would argue that that's value. Well, I take it back. I used to say no one would argue. Robert Kennedy Jr. argues that this is not value because he says, well, we shouldn't be vaccinating people, whereas vaccines are the poster child for improved outcomes and decreased cost of care. Okay, so I have to modify my talk yet again. Now we can have a situation where if the outcomes remain the same, but we decrease the cost of care, that still is positive value. And the same thing is that if we can achieve improved outcomes for the same cost, that also is value. So those are the greens. Those are the ones we want to do. Now we have trade-offs. We have these yellows. So let's say we increase the cost of care, but we improve outcomes. And the example I use here is chronic myelogenous leukemia, for which we had no treatments for years and years and years. And then imatinib came along. And we finally had a treatment, an effective treatment for individuals with this disease. But it was very expensive. Now in the UK, they have a group called NICE, the National Institute of Cost Effectiveness, where they can actually look at this and say, okay, can we afford the increased cost of care for this increase in outcome? And they can make a rational decision. And we don't have anything like that in the United States. What we have are payers. And I can tell you that every payer in the country covers an imatinib for chronic myelogenous leukemia. It's a very poor surrogate, but it is a surrogate that says that as a society, we have decided that the improved outcomes are worth increasing our cost of care. So And again, we have, if cost of care is unchanged and the outcomes are unchanged, you might consider implementing that if it, in some ways improves, some other experiential thing that we're not considering. You could maybe consider a minor worsening of outcomes if the cost of care was dramatically decreased. Institute of Medicine, Preventive Services Task Force got into those waters somewhat messily a few years back when they said, if you don't have high risk, we should initiate mammography at 50 rather than 40, okay? We're spending a lot of money on 40-year-olds. We're doing a lot of interventions on 40-year-olds, but the actual, but it's costing us $2 million per quality adjusted life year. It's not a very good value. So we go to 50, we're going to improve that equation, but we're going to miss more people with breast cancer, okay? Well, with the hue and cry, I think we can say we were not willing to make that trade-off, but there could be situations where we would. Unfortunately, and in the United States in particular, we spend way, way, way too much time in the red, where we do things to worsen outcomes and increase the cost of care. And the best example of this was about 30 years ago, maybe 20 years ago, when a bone marrow transplantation for advanced breast cancer was put forward. And there was a lawsuit in Southern California where an insurance company had denied coverage on the basis of experimental investigational. And the woman and then eventually the family after she died sued and won an $85 million settlement against the healthcare insurance company. And overnight, every healthcare insurance company in the country covered bone marrow transplant for advanced breast cancer. When the studies were finally done, what they found was not only did it not improve outcomes, but it worsened outcomes, that women that received bone marrow transplantation died faster than women that didn't. And we spent about $2 billion of healthcare on bone marrow transplantation in this sector. And we do this all the time. So that's why value is important. So let's talk about value from the perspective of our program. So we've had several publications that have come up. This was our first one from 2018, where we looked at BRCA 1 and 2 return results amongst our participants. And so we identified individuals that either had prior clinical testing, but we also looked, did they have a personal history of cancer? Did they have a family history of cancer? Because we were interested see, did people follow the clinical guidelines for actual clinical testing or not? But then we applied a clinical screening criteria, and then we looked at the differences in disease penetrance between the variant carriers identified through our biobank and those that were clinically identified, and looked for gaps in clinical testing. So the first results we found were reassuring in the sense that if you were a carrier of one of the variants that we had flagged, your historical risk of breast cancer was about 20% versus a non-carrier of 5%. So the odds ratio was about 6, highly significant. So, and then when we looked at ovarian cancer, even more dramatic. Carriers had a 10% risk of ovarian cancer versus 0.5. So an odds ratio approaching 20. So what that told us was we didn't have to worry about the situation that people were saying, well, if you screen and you find variants, you're going to find a bunch of people that don't have disease. Well, clearly these people had disease at a higher rate. We found a ratio that was about what we see clinically. 2/3 have a BRCA2 variant, 1/3 BRCA1. The prevalence, when we corrected for relatedness in the population, was about 1 in 180. Only 18% of those individuals had prior clinical testing. Very small number. And we said, well, okay, let's figure out why the reason was. Well, 50% of them didn't meet clinical testing criteria. Okay, so NCCN had said, if you meet these criteria, you should have clinical testing. And half of them didn't. So you can't criticize the care because they were not, and the guidelines are insensitive. And we kind of knew that, but we didn't know the magnitude of that.
So it was just family history of breast cancer,
personal or family history of breast cancer, personal or family history of ovarian cancer. All individuals with I think the way it was at the time of the study was that if you had a personal history of breast cancer and a family history of breast cancer, you were recommended for testing, or if you had a very strong family history of breast and or ovarian cancer. And I think anyone with ovarian cancer at that point was recommended to have testing. What we found was that of the 50% that met criteria, 3/4 of them did not have a clinical test. So of those that met criteria, the vast majority of them were not receiving clinical testing. And, you know, there are any number of reasons why that is, but care gap. So then we looked across those 3 tier 1 conditions, and this was one that came out in 2020. So this is hereditary breast and ovarian cancer, Lynch syndrome, and familial hypercholesterolemia. 350 patients, double-coded chart review with a median follow-up of 22 months. So this was beginning to look at, are people following advice? So, you know, nearly 90% were unaware that they carried the variant. Nearly 90% were eligible to perform some type of risk management. And reassuringly to us, 70% of them performed some management. They made a health behavior change that was based on the recommendation. And that was really kind of stunning to us, because if you look at the literature about health behavior changes, there's nothing that moves the needle quite that much. And so while I'm frequently say we shouldn't be treating genetic information as exceptional, maybe there is something exceptional about this when we convey it in the context of disease and screening. And about 13% of individuals, we made a diagnosis of a condition associated with one of these genes in the follow-up period based on a test that was done for the recommendation. So this really provided some additional support that the screening program was in fact providing value. And then this is a paper that just came out this year that looked across our program over a longer time period. These are figures from the program. You can see here in the lower bar graph, the darker blue-green are CDC Tier 1 conditions, and then the others are other conditions. And you can see that the breakdown, most of them are cancer, cardiovascular, with a small smattering of others. Awareness, more people were aware clinically, because I think we've been doing this in cancer for a longer period of time. So people are getting a little bit more clinical testing in cancer, but you can see in cardiovascular disease and in the other conditions that there's almost no awareness in the population that they're at risk. I wanted to talk a little bit about cost effectiveness because we've been now using the outcomes data to along with literature data to look at cost effectiveness. If we were to do population screening for Tier 1 conditions, what would that look like? This is a collaboration between University of Washington, Vanderbilt, and Geisinger. We've published individual cost effectiveness papers on BRCA1 and 2, Lynch syndrome, and FH. This was the paper that combined all three into a model. I'm not going to go through the Markov model. You probably have all seen those, but trust me, it works. And so when we did the individual models, what we found was that if you initiated screening based on a hereditary breast and ovarian cancer variant at 30 years of age, it actually met what we define as cost effective in the United States, under $100,000 per quality. But none of the others as a standalone were cost effective. But when you combine all of them and also add in cascade screening, so that's trying to capture that family component, what you can see here is that our incremental QALYs per 100,000, it's relatively flat with just a slight peak around age 25 to 30, and then with a fall off. And the reason for the fall off over time is because people have incident disease. And so if you have incident disease before you return a screening result, then you basically are not saving any money. And then when you translate that into cost effectiveness, what we found was extremely good cost effectiveness. Basically initiating screening anytime between 20 or 40, we're between $50,000 and $100,000 per quality. And of course, as you get older, then the cost effectiveness tends to go away. But I think the minimum, although it's a modest minimum, is right around 28, 29, 30. So I would contend, based on those data and others that have come out of other programs, that screening for tier 1 conditions provides an excellent model for genomic screening. And it likely has a beneficial risk-benefit profile and provides good value, but we need to have more data on health behavior changes, how much is attributable to this returning the result. And we also, this was evaluated primarily in, granted, a rural population, which is underserved by definitions, but we are not diverse unless you consider Italians and Germans as being diverse. We have very little other diversity in our population. And so we need to extend this into other populations with more diversity, which is what all of us has been trying to do. And then we also need to focus on outcomes of implementation. Combining conditions is essential for economic value, but we have to restrict the combinations to those with good clinical or patient-centered value. We can't just assume that, hey, more is better. The more we screen for is better. That way lies madness. And obviously, different screening applications are going to vary dramatically in value. So I don't know where we sit on the value plot yet, although I think probably in the upper right-hand corner there, with an argument emerging that it probably, the improved outcomes are worth the cost. So what could this look like if we really imagined, an ideal scenario? So we have a primary care patient, and at some point they have genomic screening. And we screen that sequence for monogenic disease risk, maybe as more evidence develops, polygenic risk, and also pharmacogenomics. And we disclose those results that are actionable. And we provide care coordination. We provide cascade testing for family members that haven't been screened. We look then at longitudinal risk management. But there's something about genomic data that's different from all other kinds of healthcare data. It's persistent. So if we do that sequence, we shouldn't just throw it away like we do with everything else. We should store it, and we should go back to it, and we should reanalyze. So as we learn more things about screening, as we're doing in our project, we should rescreen people. And if there's a new finding, we should return that to them. But people develop disease. And so there's a whole bunch of disease that's genetic that you would never screen for, like epilepsy, where there's 1,000 genes involved. You would never do population screening for that. But if somebody develops seizures and you have the sequence, you could do an in silico analysis to say, is there a variant in a known seizure gene that's likely to be causal? And so you can basically avoid the whole idea of somebody having to think about, oh, gee, I wonder if this could be genetic. And that's actually the focus of my current research project, which you're not going to hear about today.
I just had a question. If you go back, what would trigger that genome sequence in primary care?
That's a longer discussion, but it wouldn't be the doctor, is the short answer, okay? Because we can't count on doctors to think about it. So what we're working on is a project where we have 3 components. Identification of a high impact phenotype. So I'll just use seizures as an example. Somebody presents with a seizure. That would be the trigger to say they've got a sequence. We will do a virtual analysis of all known seizure genes, and we will filter that to identify variants that we think are likely causal. There will probably be a little bit of human annotation in there, at least for the present time. And then that would be returned to the clinician automatically saying, hey, you know that patient you just saw with a seizure? We think it's due to this genetic cause. And by the way, if you're empirically treating them for their seizures, we would suggest you use this one based on what we understand. And whatever you do, don't give them that one because it's going to make the problem worse. So we can use that sort of behind the scenes, what we're calling real-time genetic diagnosis, to develop a number of triggers that are not dependent on human in the loop to try and say, oh, gee, I wonder if this could be genetic.
Yeah, I would just think that some conditions would be better for
Yes.
that than others.
Right. And that's where the work that we're doing, we're working with clinicians. And we started with nephrology just because there's been a lot of recent scholarship about the undiagnosed genetic burden in chronic kidney disease. And we have nephrologists that are really interested in this and have been working with the MyCo data. So our first use cases are looking at autosomal dominant polycystic kidney disease, which is a pretty easy phenotype. You had an imaging study, you've got cysts in both kidneys. Okay, we can look then at the known ADPKD genes, and then we're also looking at Alport syndrome. So, and we're looking for your interest in diabetes. If we think about diabetes, we diagnose a lot of people with diabetes, but we know that 2% have monogenic diabetes, and we treat them differently. Well, if you had their sequence, you don't have to think about, well, I've got to test everybody, for genetics, because that's not a efficient strategy. But you have the sequence. When somebody has a new diagnosis of diabetes, you look at the 6 genes that are associated with monogenic diabetes, and if you find something in GSK, you send that back to the clinician and say, hey, don't start insulin on this person. In fact, you may not need to treat them at all because this may be benign hyperglycemia. So that's our next use case is endocrine disease. I mentioned NHGRI is funding genomic enabled learning healthcare systems. These are the sites that received awards, Boston Veterans, Geisinger, Indiana University, Northwestern, University of Utah, and Vanderbilt. Vanderbilt is also the coordinating center. And the goal of this is to promote broader adoption of genomics in clinical care where there is clear evidence. And we want to achieve this by developing and validating tools and resources that can be widely applied using the tools of implementation science. And then if we can demonstrate and prove that these can enhance adoption, they'll be shared broadly and gather evidence about the impact. So that's what we're trying to do. The status of that is we're about a year in. A number of work groups were created to produce structured abstracts for projects. And those structured abstracts were reviewed by all the grantees, were refined, and then the final abstracts just went through a prioritization vote. And the first project that was chosen was point of care cancer genetic testing focused on colorectal cancer. So we're just in the process now of developing how are we going to do the implementation. So pretty early days, so stay tuned. And at least to this point, we have not been told we're not going to be funded. So at any rate, to sum up, implementation of genomic medicine using learning healthcare system model can be used to develop evidence-based best practices. I hope I've convinced you of that. No big surprise, we have a lot of care gaps. And it's not just for patients with genetic conditions, but I'm a geneticist, so that's what I'm focused on. And they're pretty big care gaps there. But we have to study the delivery models themselves so that we can identify those that can be replicated and disseminated. And we have to understand value. If we don't understand the value proposition from all of the different perspectives, from patients all the way up to our organizations, it's not going to work. But at the end of the day, it does impact the life of our patients. So this is, the damn it, Spock, we're talking about human lives moment of my talk. So this is our department as of 2024. So, again, the problem with being the sole person representing this is that sometimes people think, oh, he did all this work. Well, no, these people did all the work. I just have the fun of being able to present all the works. I was lead author on this article in Health Affairs from 2018 that specifically was the first article to really talk about how we're implementing a learning healthcare system within genomic medicine. And I want to thank you.
Got a few minutes for discussion and Nora will help with the online questions.
There was some discussion in that chat.
Okay.
Here, so I'll change.
Okay.
So there's been a big discussion.
Now, there's been a bunch of comments, but yeah, so you could, if you want to click on.
Okay, so
Triage, that's you.
yeah, let me just kind of go out. I want to make sure I don't miss anything here. So, okay, so I have the gray bar so that we don't need to solve that problem.
So Dr. Dan Mark Harper had
Yeah.
some questions before, and I think you answered some of them. I think right.
Yeah, so hopefully I've addressed those questions, although I'd be welcome to. So isn't value measured by utility? Yes, that's what Hal says, but what I say is it's much broader than just utility. The value derives from a number of different things. So we have to encompass how the value proposition looks from any number of different perspectives. Utility is clearly one of the most important, but again, that utility has to be filtered through what does the patient really want to accomplish, because if we say, well, utility is disease-free progression. And if the patient's desire is not cure, but is, quality of life, well, we're measuring the wrong outcome for that individual. That utility doesn't relate to them. So it has to be a little bit more broad, which makes it harder, but, And then the next question is, okay, why don't we do genetic screening at birth? So there are people that are advocating for this as part of the newborn screening project, and there's a very pragmatic reason to do it. It's really the only time that we capture everyone. About 97, 98% of individuals in the country at the present time undergo newborn screening. And so it's unnatural to kind of fold in sequencing as part of that. Now, operationally, I think there's a huge number of things that would need to be discussed there. First of all, we're talking about the vast majority of that information is not going to be used at the time of newborn screening. And it's certainly not going to replace analyte-based newborn screening. As I always, tell people when that question comes up, I said, okay, so do you want me sitting in my room on a computer looking at a variant in phenylalanine hydroxylase and trying to impute the phenylalanine level when I can actually just measure the phenylalanine level? So this gets to the same sort of issue of how proximal or distal do you want to be for outcomes? If you can measure the analyte level, you measure the analyte level. You don't try and impute. So in my view, at least, sequencing will never replace analyte-based newborn screening. That being said, there are some things that you could argue would have sufficient utility in childhood where population-based screening in the newborn period using sequence might be worthwhile. And that's been looked at. There was a series of funded projects looking at sequencing in the newborn period that was out of NHGRI several years ago. Frankly, they ran afoul of CDC and FDA in terms of actually being able to do the project. So there wasn't a lot of data that came out. But it at least began to collect some ideas about attitude. But then you have to say, okay, well, fine. Where do we store the data? Who has access to the data? Who is responsible for screening the data at different time points? So there's all these sort of operational questions that that need to be answered. So, somebody mentioned my favorite condition. Dr. Anderson mentioned CHARGE syndrome. So. Although I would argue clinically CHARGE syndrome is really easy to diagnose, although the genetic cause is sometimes elusive if it's not CHD7. But but again, I think where the sequencing in the newborn period could be more useful is that a lot of genetic disease manifests in childhood. And so if you had that sequence, you could see indication-based testing. And actually, the use case that we use for our proposal for the real-time genetic diagnosis project that I alluded to earlier was epilepsy. And we looked at 20 kids in our population that had a genetic form of epilepsy. And we asked the question, how long did it take us from that first seizure to when we made the diagnosis of a genetic form of epilepsy? The median time was 3.5 years with a range of 2 to 14 years. We also then created care paths and longitudinal care diagrams that showed how many outpatient encounters, how many inpatient encounters, how many imaging studies, EKGs, referrals to outside experts occurred in that interim. Whereas if we could have made the diagnosis right off the bat, we could have avoided that. The other thing we found that we weren't looking for was that half of the kids were on an anti-epileptic medication that was contraindicated based on their genetic diagnosis, either because it was known to be ineffective or it actually would worsen seizures. So there is an example where if you had that sequence available and a child developed a seizure, you could do what I had talked about earlier, which is to go in there, do an indication-based test and say, is this a genetic form of epilepsy, of which about 40% of them are? And we could use then condition-specific management, right off the bat. So I think there's tons of interesting use cases there. And in some ways, despite all the hoo-ha, there are reasons that I'd like to be 25 rather than 70 to be able to pursue some of this, but I'm going to be pursuing other things. So, yep. Okay. Yeah. Yeah, so the issues of consent, absolutely, I think, an informed consent, model would probably be, it's interesting whether this may be sort of an exceptionalism argument here, which is to say, we don't do specific informed consent for other forms of population screening. We consider that to be covered under the consent to treat. So mammography, colonoscopy, things of that nature. You get a procedure consent for colonoscopy, but that's a little different than I think the intent of this question is. And so then the idea is, okay, well, is a screening program based on genetic information so inherently different that we need a different consent model for it? And I think there's been some emerging scholarship about that. The major takeaway is that our patients really don't think it's that different. As I said, we did all these interviews prior to the MyCode project, and one of the things we specifically asked about is, well, would you be concerned about getting bad news based on this genetic sequence? And they say, we get bad news from you guys all the time. You tell us we have cancer and you tell us we have lipid disorders, so we're used to getting bad news from doctors. What makes you guys in genetics think you're so special that your bad news is worse than all the other bad news we get from you? And it's just kind of like, okay, yeah, I guess you got a point there. But we've, one of the great things and one of the worst things about the Human Genome Project was that 5% of the budget was devoted to ethical, legal, and social issues, okay? Well, that meant a lot of money went to a lot of really smart people that could sit around rooms and develop doomsday scenarios of what could possibly go wrong because they were getting paid to come up with doomsday scenarios. If you actually look at how much has gone wrong, there's very little. Now, some of that is because we've been proactive about doing things like the Genetic Insurance Non-Discrimination Act. And of course, we also got an additional level of protection from the Affordable Care Act and pre-existing conditions. But the predicted harms, the hypothetical harms that were raised, for the most part, have not been realized when we've actually applied genetic and genomic information, which is not to say we should have a Pollyanna view of it. But it is something where I don't think we necessarily need to default to say we need we need to have an entirely specific system for genomics as opposed to everything else. So,
Mark, can I jump in with a question? In that cohort where you have 300,000 people, a decision was made, and you talked about the criteria you used to screen for a certain number of conditions, prioritizing specificity over sensitivity. Who made that? But who made the decision to screen for that particular set of 28 or 33, whatever the current number is?
Right. So the specific decisions are made by a group of geneticists, genetic counselors, and others that then bring those decisions to non-genetics clinicians in the system as a whole. But one step before that, so to answer an implied question, we don't have patients sitting around the table that are involved in those decisions. But what we did do is in the initial informing sessions and in our ongoing consultations, we have set up sort of what are the general parameters. Now, the interesting feedback we got from patients is we said, okay, if you're in this research project and we find something that's relevant to your health, do you want us to tell you about it? And their response was, why wouldn't you tell us about it? Well, you see in research, we do this stuff and we find stuff and we don't tell people about it. That's the standard. They said, well, that's really stupid. I said, yeah, it is kind of stupid, isn't it? So they said, if you find something that's relevant to our health, we want to know. And so as part of the consenting process, we tell them, we are going to look at it. If we find something that is relevant to your health, we are going to return it to you. There is no opt-out. If you don't want that information, don't consent to be in the project. So that's the key message that we give at the time of consent. And yet 75% of people still consent to participate in the research project. And so then we said, well, and there's going to be some things we find that we don't exactly know what to do with, but it might have some relevance to your health. What do you think about that? I said, well, you can give that to us. I said, we know you guys are busy. You're not going to get to everything. We can take some of that ownership. We can maybe do some of our own work. How about stuff we know nothing about? Oh yeah, we're fine. Just give that to us. They wanted everything. And it's like, we're not giving them everything, okay? We made the decision. It wasn't feasible for us to do that. And we also thought, but it reflects a very different perspective of the person on the street in terms of their concern about this as opposed to the concern that we've raised about it. So that's a semi-answer to your question.
Well, just to follow, can I do a follow-up?
Yeah.
So you started this talk with precision medicine.
Yes.
And one might assume that every one of those 300,000 people wants to be on a different place on the ROC curve. Leaving aside the procedural difficulties of making this happen, couldn't you report individually, precisionize the reporting threshold to where that person wants to be on the ROC curve, and then you'd have a precision medicine approach
Yes.
to your screening?
Yeah, absolutely. But I'll quote Yogi Berra, who said, in theory is better than practice. In practice, it ain't. I think theoretically, while that would be great, there are pragmatic things in terms of the resources that would be needed to develop individualized prevention for 300,000 people. But on the flip side of that coin, we are woefully underprepared to do the type of engagement with individuals to really understand what they want and how those wants change over time. And because we know, and as we return results to folks, we know I'm dealing with something in my life right now that I just don't have time for this, but call me later. And in a year, they're ready to hear about it. And so, those are the sorts of dynamic issues where if you think about the ideal state, that's exactly what you would want. You'd want some sort of a dynamic interface that would allow you to fine tune this because maybe they're really interested in breast cancer, maybe they're not so concerned about, heart disease. But maybe you could also tailor the preventive message that they say, you're concerned about your family history of breast cancer. We don't have any genetic results, but here are some things you can do to minimize your risk. They just happen to overlap with some of the things you would use to minimize cardiovascular risk. And so we use readiness to change to target a message that they may be more willing to act on.
This genomics learning health system at Geisinger, is this a rare phenomenon, or are there multiple systems that have similar models?
It's more exceptional than, there are a handful of groups around the country that are doing things like this. We're the largest healthcare system-based one. All of us is now a bit larger than we are, although we've returned more results than they have. But there are groups. Vanderbilt has been doing this for a long time with pharmacogenomics, but pretty limited to that. North Shore has a little bit more comprehensive program, although they have, I think, maybe 10,000 or so that they've gone through. And there are a handful of others. There's even some countries that are involved in this. So Estonia is a really interesting use case. There's 300,000 people in Estonia. They have a single identifier for everything. So your driver's license, social security, health insurance, everything, it's one number. And so they can pull data from, they know who that person is, and they can pull any data that they want and accrue that. And so they started a biorepository with sequencing. And so they began to publish some of their outcomes data relating to familial hypercholesterolemia and some of these other sorts of things, looking at it from a countrywide perspective, which is really fascinating. So if you're not familiar with that, I highly recommend seeking out information on that. I had an article, I think it's about 3 years ago now, in a year in review, or I'm sorry, an invited review article on genomic screening programs, population screening programs. And if Noor sends me an email, I can send that and distribute it to who's ever interested.
I've got a question.
Yes.
When you introduced the MyCode project originally, you had this really wonderful phrase where you said, and then of course we built the infrastructure. And so I'm curious to know, what kind of infrastructure did you have to build to make this work? And how did the co-design, even though the patients didn't collaborate in actually building the infrastructure, how did the co-design process shape how you built the infrastructure
Right.
for MyCode?
So some of the infrastructure actually did exist. We just needed to ramp it up a bit. So we had a multidisciplinary hereditary breast and ovarian cancer clinic, and we had a hereditary colorectal cancer clinic. So we had existing infrastructure that would support that. So we just needed to be able to provide additional information to those existing clinics about how this type of an identification would, inform that and provide additional resources to them, and also make sure, have an honest conversation with them about capacity. And you accept, if we add 100 more patients, in a year, is that something that you could absorb? We had a couple of practitioners in the system that were doing specialized lipid practice, but we knew we didn't have the capacity there. But, most clinicians are pretty comfortable with lipid management. And so what we needed to do then, and we've had a couple of funded research projects that had looked at how do we actually deliver messaging through the electronic health record to support individuals that are at higher risk for poor outcomes from lipid disorders, so that they can get more appropriate treatment based on their underlying condition. That had an unintended consequence in pediatrics, which was actually really interesting. So we were identifying kids that had familial hypercholesterolemia, and you can initiate statins in kids at 8 if they, have LDLs that are above 160. And so we were talking with them about that. And I always bring up, as a pediatrician initially, I say, and of course you guys are already familiar with the fact that the AAP has lipid screening guidelines that every child, should have a lipid test done, after the age of 6. We also know that fewer than 10% of those kids actually get that lipid test done. Well, when we had this conversation about identifying these kids, we revisited that, and the Department of Pediatrics, without any prompting from us, said, we need to implement a process to close this care gap. We're not following what our professional society says we should be doing. So they created a program to make sure that all kids got lipid screening according to the AP guidelines. And that was, it was not because we told them to, it was because we just, pointed out, you got a big care gap here, and they said, this is one that's important enough for us. So you sometimes never know where things are going to go. And that was an infrastructure that was created independent. And then for some of the rarer disorders, we've identified specific clinicians that have an interest. So we have one cardiologist who's interested in transthyretin amyloidosis. So we worked with him to say, okay, we're identifying a lot of these TTR variants. What do we do there? Cardiomyopathy, endocrine tumors, those sorts of things. So we've been able to basically, either through interested clinicians or through existing multidisciplinary clinics, capture all the things that we're doing. But we do it proactively, so when we turn it on, we know where to send people.
Got time for one more relatively short question, either from the room or from the chat. I think Dr. Hurwitz has. Oh, good.
Okay. I've had people question doing clinical testing for developmental disease in the NICU because early discovery may lead to family disengagement. That's interesting. Imagine a routine genetic screening that increasingly defines a person's risk. What does that do for the family and eventually the child? Yeah, you know, again, my training's in pediatrics, and I must admit that comment doesn't fit with my experience. I know that there was a school of thought about creating the vulnerable child. That if you focused on these illness things, that you would create in parents a sense that their child is vulnerable and they would treat them differently and they would become more socially isolated and not develop. And I think, again, that was work that was done in the 70s and 80s, and I'm not really sure that that has sustained as something that's really of concern. I think my experience as a pediatric geneticist is that the uncertainty relating to not having a diagnosis is way more damaging to individuals than having a diagnosis, even if it's a terrible diagnosis. And it's not to say that there aren't exceptions to that rule, but the uncertainty just absolutely destroys patients and families because they just don't know where to turn and they don't know what to do. And so they're following all of our recommendations, but nothing seems to work. Whereas if you can make a diagnosis, maybe you're in a situation where you say, well, there really isn't anything to do. Now you can change the conversation to say, well, let's change our goals of care. And I think we've seen this in the rapid newborn sequencing where a proportion of those individuals are identified with an untreatable fatal condition. And what has been shown is that the families are comfortable transitioning into palliation and feel overall that it's a more positive experience as opposed to having months and months and months of a child that's receiving intensive care and then ultimately passes away without knowing. So I can't relate necessarily to that particular comment, and I know it wasn't necessarily your comment. You're just relating it. That's my experience.
But Mark, first of all, thanks very much for this
We're gonna
lecture.
unmute you, Ed. So hang on just a second.
Oh, what's going on? What's causing that? Okay. How about now? It's good? Okay. So Mark, first of all, thanks very much for this lecture. I'm Ed Hurwitz. I'm one of the LHS collaboratory leaders. I'm sorry I could not be there in person today. That chain of comments was about the idea of why don't we just take every baby and do a full genomic analysis? And I don't think we know enough about the effects of that yet to really start thinking about that. So I hear what you're saying. If a child has symptoms and signs, and being a pediatric physical medicine rehabilitation doctor, I know the value of early intervention therapies and so forth. So that's why I know that question, because we were developing an early intervention, early diagnosis program that came up. But I don't know. What about finding everything and any? We're going to be doing so much more every year. We know so much more. Do we do everything and anything on a baby so that they grow up with that their whole life and get treated that way, or do we let them make the decision when they're, I don't know, a certain age?
That's a really that's a really interesting question, because what you're talking about is the loss of choice and the ability to make decisions as a competent adult as opposed to having parents make decisions for you. That was actually the subject of the first, and to my knowledge, only a study that we were funded to do, looking at the return of adult onset condition results to pediatric patients, which we did as part of the MyCode, but under a very strict research protocol, because the admonition against returning adult onset conditions to pediatric patients, all of the practice came back to a single article written as sort of a, we should maybe think about this. Actually, the person that wrote the article was on our research team. She said, I didn't intend this to be the way that everybody treated. I thought it was an important question to ask. And then everybody said, oh yeah, we shouldn't do this. And so it was the first actual empiric study of looking at that. And what we found was similar to what we found in other studies of looking at return of genetic information, which is all of the things that we had concerns about in terms of loss of choice, loss of autonomy, changes in self-perception. We measured all that in the kids and in the families, and we found essentially no signal that would indicate that this was having a negative impact, even though it was something that the children were not going to really act on until they were adults. So again, a very small study, very preliminary, certainly not something where we should make policy decisions, but we need more of that empiric research as opposed to saying, I think it's a bad idea and then acting on it.
Thank you so much for starting this great conversation. I know that it could go on for much longer. It's time for us to wrap now. So please join me in thanking Mark one more time. Thank you for everyone
And
joining
online as well.
Yeah. And then if anyone needs to claim CME credit, I will email you the code. Thank you, everyone.
Oh, it's a downfall. My watch.
Wiggle around.
Get up.
I know, right?
Lazy, yes.